This is a rare case of a sciatic hernia managed with robotic mesh repair. The patient is a 66-year-old female with an incidental finding of a right-sided sciatic hernia on an MRI done for refractory diarrhea. Her history was relevant for multiple surgeries, including a hysterectomy, a laparoscopic cholecystectomy, 2 diagnostic laparoscopies, and an exploratory laparotomy with ileocolectomy for small bowel obstructions. This slide shows the patient's MRI, in which we can appreciate a protrusion of abdominal contents through the sciatic foramen. It's important to remind ourselves of the relevant anatomy pertinent to sciatic hernias. In this representation, we can see a clear correlation with the ureter as well as the iliac vessels. Her surgery started with lysis of adhesions using sharp dissection. After that, we were easily able to identify and expose the right sciatic hernia defect, which measured about 1 by 1 centimeters in diameter. Important anatomical relations to the defect were the right ovary and right fallopian tube. We also identified the right ureter, which was inferior and medial to the defect, as well as the right iliac vessels, which you can see lateral and superior to the hernia defect. We then inspected the left side and found no evidence of a sciatic hernia on that side. Patient also didn't have any evidence of inguinal hernias on either sides. We started the repair of the existing hernia by creating a peritoneal flap in order to access the preperitoneal space. After completing the incision in the peritoneum, we dissected the preperitoneum space in order to create a pocket large enough to accommodate an appropriate size mesh. During that dissection, care was taken not to injure the ureter or the iliac vessels. We were able to identify the right sciatic nerve during the dissection. The hernia sac was then reduced. It was found to be much larger on its depth than it was on its diameter. The depth of the sac was about 2 to 3 centimeters deep. We placed a single stitch to approximate the preperitoneal fat in order to protect the nerve and the ureter from the overlying mesh that we were about to place inside the pocket. We used a 6 by 3 inches large pore monofilament soft mesh cut to the size of 3 by 3 centimeters inside the peritoneal pocket. We made sure that the mesh was well positioned, lying flat, large enough to cover the whole defect, and completely covered by the peritoneal flap. When we were happy with the positioning of the mesh, we used a barbed suture to close the peritoneal flap and secure the mesh in place. We also included the hernia sac into the closure of the peritoneum. Our patient had no postoperative complications. She was discharged home on the same day of the surgery and was found to be doing well on her follow-up in clinic after 6 weeks. Interestingly, she had had no more episodes of diarrhea after the surgery. Sciatic hernias are rare conditions, and therefore it's not surprising that most of the literature available on the topic consists of small case series or case reports. This paper found only 99 reported cases of sciatic hernia in a span of 180 years. Only 4% had bilateral sciatic hernias, and there was no evidence of correlation with prior pelvic surgeries, such as hysterectomies, as seen in our patient. The presentation varied, and it's unclear whether or not the diarrhea in our patient could be related in any way to the sciatic hernia. Her previous episodes of small bowel obstructions also may or may not be related. Looking at the management of sciatic hernia, we can see a transition between a transgluteal approach in the early 1900s to a predominantly abdominal approach in more recent years. We can also see laparoscopic surgery coming into scene about 20 years ago, and now robotic surgery as well. This video was produced by the Washington University in St. Louis Division of Minimally Invasive Surgery.